Hi guys, this is Lab 18 review on the duodenum, pancreas, spleen, and portal vein. Hopefully this will be a quick one, but we know how that goes. So anyways, we're going to start with this much, which is exciting. All right, starting off with the duodenum, we have the, can you summarize the different parts? Well, we have 4 parts. We have the superior, aka first part, we have the descending duodenum, we have the transverse, aka horizontal, aka third part, and then we have the fourth part, which is the ascending duodenum. The superior duodenum actually has 2 parts, a proximal part, which is adjacent to the pylorus of the stomach, and it's got a smooth interior, and then we have this distal part, which looks more like the rest of the duodenum with the permanent circular folds. And overall, this first part right here is intraperitoneal. Then as you get to the distal part of the superior first part of the duodenum, becomes retro, and then retroperitoneal overall. Okay, descending, so first part, descending part is retroperitoneal, as we said, and then this guy, as we'll see, contains the hepatopancreatic ampulla, which is where the bile duct, the common bile duct, and the pancreatic duct drain into. So our bile and then our pancreatic enzymes are going into the small intestines here in the second part. Then we have the transverse section that passes anterior to, as we'll see, the inferior vena cava, and then we will talk more about that. Then you have the ascending part, which is 2.5 centimeters long. It's retroperitoneal, except for at the very end where it becomes intraperitoneal as it goes from duodenum to becoming jejunum at the duodenojejunal flexure right here. Okay, and then importantly, this fourth part right here actually has a ligament that supports it. It's this suspensory, we were told muscle in lecture, but I think ligament is correct, from the right cruce of the diaphragm, and it holds this guy in place. And this ligament is also called the ligament of Trias. You can see it's coming from the right cruce of the diaphragm. This is the left cruce over here, and you can see it's coming to the fourth part of the duodenum, the ascending part, to hold it in place. Great. So first part, second part, third part, fourth part. Not too bad. Let's move on. All right. Internal characteristics. Well, we already kind of talked about this, but the superior part we said has a proximal and distal part. And the proximal part's got a smooth lumen. It's the most prone to ulcers because it's next to the pylorus of the stomach. So all that acidic chime is coming in here. Then we have the distal part, which has got the circular permanent circular folds, the plica circulate, that we can see throughout the small intestine. Then we get to the descending duodenum, and here's where we get to our first sort of cool thing. We have the major duodenal papilla, which is where our common bile duct and main pancreatic duct, you can see right here, come and they drain into that, and we have the sphincter of Oddi that's deep to this papilla, that's acting as a sphincter to keep those the bile ducts and the enzymes from the pancreas from going into the duodenum until it's desired. And then we also have this one, which is kind of cool. This is the accessory duodenal papilla, and you have this accessory pancreatic duct, which we'll talk more about in a little bit, but this is from the head of the pancreas, and it's this papilla is, and this accessory duct that feeds into it is present in, I think it's like 50% of people, so it's not everywhere most of the time. This like duct will just drain into this main pancreatic duct, which we know goes to the major duodenal papilla of Vater. All right, so not too bad. Horizontal, not much going on here. We just have our plica circulate, those permanent folds. Ascending part, we have our duodenojejunum flexure right here, and then our jejunum, and then we know this is suspended by our friends, the ligament of Trias from the right cruce of the diaphragm. Okay, so moving on. Can you identify parts of the duodenum based on this image? It's X-ray. So this is like kind of weird looking. We have this guy right here, which is, we were told during our radiology session, this is probably just a constriction of the muscles of the stomach that's producing this. This is our pylorus region right here. Then we have the superior part, aka the first part of the duodenum, descending, transverse, and then this appears to be ascending duodenum and or jejunum overall. All right, but this guy right here, this whole region right here is the stomach. Okay, can you relate the different parts of the duodenum to nearby organs and structures? We can sure try our best. So here we have the first part, which we know is feeding into the stomach. Well, the stomach is feeding into that. We also know that this guy right here is suspended by the hepatoduodenal ligament, which contains the portal triad. Posterior to this, we have the inferior vena cava, and then importantly, the head of the pancreas is bound by the curvature of the duodenum. So the second, third, and fourth parts of the duodenum are holding the head of the pancreas in place. And then notice we have the inferior vena cava behind things. We have the aorta, and then we have the superior mesenteric artery and vein, which are starting to come over the top of this third part of the duodenum. Not too bad. So next thing we're going to talk about is where we have this jejunum and duodenal flexure right here, and that's an important part because you're going to have hernias or internal hernias, or you could have internal hernias there. All right, but actually before we get that far, we have the bile ducts. So can you discuss the anatomy of the bile and pancreatic ducts? Sure, we have our from the gallbladder, we know when that contracts, then it's going to squeeze the bile through the cystic duct and into the bile duct. We have the hepatic duct overall, which will come from the liver and go to our common bile duct. Then we have that go into the hepatopancreatic ampulla of Vater. And that ends in the major duodenal papilla right here, which we can also see here, this little opening into the duodenum. And then we have a bunch of different sphincters. We have the big sphincter, the sphincter of hepatopancreatic ampulla, also called the sphincter of Oddi. Then we have the sphincter of the common bile duct right there. And then we have an inconsistent sphincter of the pancreatic duct. And we're going to go over all this again. At least once more. Do you recall peritoneal folds related to the duodenum? Yes, and it's important to note that folds related to the duodenum are incessant, meaning they are variable. However, the consistent one, or consistent 3 folds, or 3 defined folds and 4 defined recesses, which should always be there. And this has to do with where the ascending duodenum becomes jejunum. So it's duodenojejunal flexure right here, you have 3 defined folds here and 4 in this region, where as a reminder, folds and recesses form where structures go from retroperitoneal to intraperitoneal, and so really this is where duodenum is coming from retroperitoneal and becoming intraperitoneal as the jejunum. All right, so we have we said 3 defined folds. That's the superior duodenal fold, the inferior duodenal fold, and the paraduodenal fold. And each of those have a recess associated with it. Importantly, the paraduodenal fold contains the inferior mesenteric vein, and so we'll see that more when we talk about clinical correlation. And then we have a fourth recess, which is the retroduodenal recess overall. So in this region right here, we have the first fold is the superior duodenal fold, right, just superior, upper. Then we have the duodenal fold, which is more lateral, and then we have the inferior duodenal fold, which is inferior. Okay, and then in terms of the recesses, I found this diagram online, but the superior duodenal recess would be back here, and then the inferior duodenal recess would be back here, and then you have a retroduodenal is behind this guy right here, so it's going to be like back there, and then what are we missing? There is a fourth one. Paraduodenal recess is going to be, should be over there. All right, so not too bad. Let's look at the blood supply, and then we'll talk about the clinical correlations. Okay, so blood supply to the duodenum is really coming from two main parts, and that would be the celiac trunk, ultimately, and then the superior mesenteric artery. All right, and we know both of those are actually coming from the abdominal aorta, but the duodenum is primarily being supplied by a branch from this guy and a branch from this guy. And so the celiac trunk is going to give off our three main branches. The first one, the one that we care about here, is the common hepatic, and then the common hepatic is going to branch into the proper hepatic, and then the one we care about is the gastroduodenal branch, so this guy right here. The gastroduodenal is going to split 3 times that we care about, but 5 times overall. You have the posterior superior, so this guy right here, posterior superior pancreatic duodenal artery, and then you have the anterior superior pancreatic duodenal artery, and those are going to give off branches that supply the second and third part of the duodenum, and then those will continue down until they meet up with the second part of what's supplying the duodenum, which is a branch from the superior mesenteric artery. And so the superior mesenteric artery is going to give rise to this inferior pancreatic artery. So inferior pancreatic artery is going to bifurcate and give us the posterior inferior pancreatic duodenal artery and the anterior inferior pancreatic duodenal artery. All right, so that's going to anastomose with the posterior superior and anterior superior pancreatic duodenal artery, which we said is coming from gastroduodenal. But they're going to anastomose, and then in doing so, they form these arcades that give off straight arteries to supply the all parts of the duodenum, with the notable sort of caveat, which is a lot of the very first part of the duodenum actually comes from the supraduodenal artery, and the supraduodenal artery is from the gastroduodenal. All right, so to summarize, we start with the celiac trunk. That's going to give the common hepatic, which branches into proper hepatic. Don't care about that in this case. Then that branches into the gastroduodenal. Gastroduodenal is going to give us the supraduodenal, which supplies the first part of the duodenum. Then it branches into the posterior superior and anterior superior pancreatic duodenal arteries. Those continue down. They anastomose with the branches that come. They anastomose with the anterior inferior and posterior inferior pancreatic duodenal arteries that come from the superior mesenteric artery, which we know comes from the abdominal aorta, just like the celiac trunk comes from the abdominal aorta. All right, so not too bad. Basically, what we're dealing with is pancreatic duodenal arteries supply this region. Where do they come from? They come from gastroduodenal and superior mesenteric artery. Okay. Venous drainage is relatively straightforward. It follows the arteries. It's going to the hepatic portal system via the superior mesenteric vein, and then the right gastric vein, which isn't shown here, but it would be supplying the first part of the duodenum. Okay, just a quick note on lymphatics of the duodenum. So we have, basically, you have the pancreatic duodenal lymph nodes, which you can see here. And then you have the pyloric nodes near the pylorus of the stomach, and then you also have near the mesenteric artery, you have the, mesenteric vein, superior mesenteric nodes overall. All right, so pancreatic duodenal nodes, pyloric nodes, and then superior mesenteric nodes for lymphatic drainage. Innervation of the duodenum is similar to what we saw in the previous lab. For the parasympathetic nervous system, we're dealing with the vagus nerve, right? We know that this is all for vagus, for parasympathetic, it's all preganglionic, and then it synapses directly inside of the organ of issue. So postganglionic is like super short inside the organ of issue. Sympathetic nervous system, you have these long preganglionic, and these long preganglionic is going to come from our thoracic splanchnic nerves. If you remember those, we have greater splanchnic T5 through T9, lesser least, which is T12. So greater splanchnic is doing most of the work here. That's going to be a preganglionic neuron. Then it's going to synapse on, there's 2 major ganglions that we care about. There's 4 major ganglions in the abdominal region, but the 2 for the duodenum are the celiac ganglia, so here, and then the superior mesenteric ganglia, which is going to be here. And so we have the cell body in the ganglia for the postganglionic neuron in the sympathetic nervous system, and then the postganglionic axon is going to go directly to the different parts of the duodenum, where it will synapse on the enteric nervous system, but it generally follows the arteries overall. Okay, so not too bad. Let's move on. So clinical correlations, we said the first part of the duodenum is most prone to ulcers, right? That kind of makes sense. It's right next to the stomach, so it's going to be a lot of acidic giant that comes in each of the walls, and you get ulcers there. It's not fun. The second thing is internal hernias are important to note. The duodenum, especially where we have the ascending duodenum becomes jejunum. We said it went through, there's like 3 defined folds and 4 recesses in this area, and so those 3 folds in particular, where you go from retroperitoneal to intraperitoneal, is a site of herniation where you can have basically jejunum go into this region, and it's not great. Okay, and so, it says if acute, normally these will go undetected, but it's possible that the herniated coils can twist and become strangulated, and it's incredibly painful and require emergency surgery. And then in repairing this, you have to be very careful not to cut the paraduodenal fold, because as we said, this contains the inferior mesenteric vein, and we also know that, our venous portal system, of which the inferior mesenteric vein is a part of, lacks valves. Right? And so if it lacks valves, that means that you can have hemorrhage, sort of bidirectional venous hemorrhaging, which would be very bad if you cut the inferior mesenteric vein inside of the paraduodenal fold. Right? But remember, we have 3 folds associated with the region: superior duodenal, inferior duodenal, paraduodenal. And then we said, there's other folds that might be there, but they're variable. These 3 folds are going to be there because they're associated with the retroperitoneal to intraperitoneal transition of duodenum to jejunum. Okay, so not too bad, this clinical correlation. Next, we're looking at the pancreas. So just to start off with the basics of the pancreas, remember that it's a gland overall. So we have exocrine and endocrine gland function. Exocrine is like it's excreting onto the surface. So we have the pancreatic duct excretion. So we have trypsin, chemotrypsin, both of these are proteases, amylase to break down our sugars, and then lipase for our fats, and those get excreted via the pancreatic duct. And then we have the endocrine function of the pancreas, which is releasing insulin and glucagon into the blood. All right, so then what are the different parts? Well, we have the head region, which is retroperitoneal, and as we said, it's contained by the curve of the duodenum. It encircles the superior mesenteric artery and vein, which we can see again are coming anterior to the third part of the duodenum. And then this guy terminates in like a wedge shape overall. The head terminates in a wedge shape, which we would call the uncinate process. Probably mispronounced that. All right, then we have the neck region, which is also retroperitoneal. It's anterior to the superior mesenteric artery and vein. Right, you can see that here. They pop out after they pass by underneath the neck, and it's adjacent to the pyloric region. Then we have the body of the pancreas, ultra-retroperitoneal. It crosses the aorta, and it is posterior to the stomach. And then its superior surface, this is probably the most important part, the most important relationship at least, is associated with the splenic artery. All right, then finally we have the tail, which is in contact with the spleen, and it is suspended by the splenorenal ligament overall. And as we said, the tip of the tail usually contacts the spleen. All right, so that's the basics of the parts of the pancreas. In terms of blood flow, we've kind of already seen this, so it's not too bad, and there's a limited number of things we need to know here. But start with our abdominal aorta. We have the celiac trunk. The celiac trunk is going to break up into our three main branches, right? Left gastric, common hepatic, splenic artery. The splenic artery is our main, blood supplier, and so you can see, as we said, it goes along the body of the pancreas, and it gives off branches that go into the pancreas itself. Good thing is we don't need to know this. We don't need to know the names of these branches. For this course, we just need to know the splenic artery from the celiac trunk does a lot of blood supply to the pancreas. Okay, then the other main thing that comes from the celiac trunk is we go back to common hepatic, and we're back to, similar to, or basically the same arteries that supplied the duodenum are also supplying the pancreas, right? That makes sense because the duodenum binds the head of the pancreas. So common hepatic to gastroduodenal, we said gastroduodenal splits 5 times, but the 3 that we care about, we have supraduodenal, which goes to the first part of the duodenum. We're not so concerned with that here because we're dealing with the pancreas. But for the pancreas, we have that posterior superior pancreatic duodenal artery, and then the anterior superior pancreatic duodenal artery. And then we know those anastomose with the part from the superior mesenteric artery. And so the superior mesenteric artery bifurcates and gives us posterior inferior pancreatic and anterior inferior pancreatic duodenal artery. Okay, so not too bad. We have celiac, which gives us splenic, that gives us, and celiac also is going to ultimately give us the gastroduodenal, and then we have abdominal aorta is also going to give us superior mesenteric, and then that will give us both of these guys, which anastomose with these guys, and overall we have good coverage for blood supply for the pancreas. All right, what are the pancreatico-duodenal arteries, and where do they originate? Great, well, we just talked about this, and this view in particular is kind of weird because you can see we've taken the duodenum and we sort of pulled it over, and so we're looking at the backside of the head of the pancreas, which is really weird. So we know that these guys originate from 2 places. We had the abdominal aorta gives us the celiac trunk, which gives us the hepatic artery, the common hepatic artery, which gives us the gastroduodenal artery. So that's our first place starting for the pancreatic duodenal arteries. The gastroduodenal artery is going to bifurcate and give us the posterior superior pancreatic duodenal, and then the anterior superior pancreatic duodenal. Right, so we can see those here, and then those are going to continue until they anastomose. Right, you can see that here, and then here. Those continue until they anastomose with the inferior pancreatoduodenal artery and the anterior inferior pancreaticoduodenal artery, which come from the superior mesenteric artery right here, which we know comes from the abdominal aorta. All right, so not too bad. We're crushing it. Can you dissect the main pancreatic duct in your cadaver? Great, yeah, of course. So this begins at the tail, and then continues down the body, and then we can see that it comes and goes into the hepatopancreatic ampulla of Vater, and it opens into the duodenum via that little pore right here, which we call the major duodenal papilla, which we can see right here. And then we said that this part's not always present, but around 50% of people it is. We have this accessory pancreatic duct, which drains the head of the pancreas. But a lot of times this duct doesn't exist. But if it does, it will go to the minor duodenal papilla. If it doesn't exist, basically the accessory duct is going to just drain directly into the main pancreatic duct overall, which we know is going along the entire length of the pancreas. Okay, and then in terms of sphincters, we said that we had the sphincter of the pancreatic duct, which is not well defined and always there. We have the sphincter of the common bile duct, and then we have the sphincter of Oddi, also called the hepatopancreatic sphincter, which again ends in our major duodenal papilla, which is this tiny hole that ends up in our second part of our duodenum, descending duodenum. Perfect. All right, so pancreas, lymphatic drainage. We have basically lymph nodes, superior pancreatic lymph nodes, inferior pancreatic lymph nodes, and they all sort of end up in 3 locations. They end up at these celiac lymph nodes right here. So you have the celiac trunk, you have the hepatic lymph nodes right here, and then the superior mesenteric lymph nodes right here. And so all of these guys are going to drain into hepatic, celiac, or superior mesenteric lymph nodes overall. Venous range of the pancreas, you have the splenic vein, right? That makes a lot of sense. It goes to the splenic artery, and then the superior mesenteric vein right there, and then drains into both of those drain into the portal system, the portal vein. All right, pancreatic innervation, relatively straightforward. For parasympathetic, we have the vagus nerve, just like the duodenum. For sympathetic, we have also just like the duodenum, celiac, and superior mesenteric ganglia. Right, 2 of the 4 ganglia in the abdominal cavity that we care about. The greater splenic nerve is doing most of our preganglionic work for the sympathetic nerve system for the pancreas, and we said that preganglionic goes to the ganglia in one of these 2, celiac or superior mesenteric, and then the postganglionic axon is going directly to the pancreas, and then so pain resulting from inflammation of the pancreas, aka pancreatitis, is usually referred to the anterior upper abdomen. The gastric region can spread to the back. And then postganglionic sympathetic fibers from the celiac and superior mesenteric ganglia, together with the presympathetic fibers from the vagus, utilize the surface of arteries supplying these organs to reach their visceral targets. Likewise, visceral afferents utilize the arterial vasculature to make their way back to the corresponding spinal cord levels. So basically, as we said, the axons fold the arteries to the pancreas. All right, clinical correlations. Unfortunately, here we have cancer. So malignant tumors on the pancreas are typically in the neck or the head region. Not good. Stages 1 through 3 are confined to the pancreas. Stage 4 is when you spread to other organs. It's pretty sad. Gallstones can occur, especially if they are blocking the hepatopancreatic ampulla right here, and this is a major cause for inducing pancreatitis, inflammation of the pancreas, and then obstruction of the bile duct in pancreatic cancer. For whatever reason, can cause obstructive jaundice, and we can see lack of breakdown of bilirubin, and we get the yellowing of the sclera of your eyes. All right, surgical removal of the pancreatic tumor is very complex, usually involves resection of the duodenum and other parts of the GI tract. This is necessary because the arterial supply, the descending, transverse, and ascending duodenum, and the head of the pancreas all share blood supply via the anterior and posterior pancreatic duodenal arteries. Since most pancreatic cancers localize the head and neck region, surgical removal of both the head of the pancreas and the adjoining part of the duodenum is performed. This is called the Whipple surgical procedure. So you can kind of see that here. Whipple, if you have cancer here, you're going to be removing all of this because it shares a common blood supply, and then we've basically attached the common bile duct to what remains of the duodenum, or this may actually be a jejunum, and then the pancreas is attached to that as well, and then the stomach is attached to small intestine as well. So a Whipple procedure. All right, can you describe the anatomy of the spleen? And is your cavity normal size? Ours was, yes. But as just a quick review, the spleen is the largest mass of lymphatic tissue in the body, lymphoid tissue in the body. It's a peritoneal structure, so not retroperitoneal. And then we have this sort of visceral surface named because it's in contact with organs, right? And then we have a diaphragmatic surface, which is smooth and convex. The visceral surface has a hilum where we have the splenic artery and splenic vein coming in, and then we have, because it's visceral, we have impressions from organs that's in contact with. You have the gastric impression, you have the left renal, aka kidney impression, and then you have the left colic flexure, colic impression at the bottom. Okay, so not too bad. Visceral surface is medially oriented, diaphragmatic surface is laterally oriented. It's against the diaphragm, which makes sense. Okay, can you discuss the peritoneal ligaments associated with the spleen? Sure, we have the splenorenal ligament right here, and this keeps the spleen located to, as we can see, the abdominal wall. Then we have the gastrosplenic ligament, which attaches the spleen to the greater curvature of the stomach. All right, can you describe blood flow? Oh, this one is really easy. So we have the splenic artery and vein, which we know is associated with the body of the pancreas. It takes this long, tortuous route, and then it splits into approximately 5 different branches in the hilum of the, well, it splits within the splenorenal ligament, which we can see, splenorenal ligament right here, which we said splenorenal ligament is holding the spleen off of the posterior abdominal wall right here. So within the splenorenal ligament, it splits into 5 branches, which goes into the spleen. Same thing with the vein, so not too much to know there. Okay, so lymphatics of the spleen, you have lymph nodes will drain into the pancreatosplenic lymph nodes, which you can see here, and they're present along the superior border of the pancreas. Innervation of the spleen, most of the autonomic innervation is associated with vasoconstriction. Postganglionic sympathetic neurons associated with the celiac ganglion, which is again one of the 4 ganglion in the abdominal region, or 4 major ones, and then parasympathetic fibers are associated with the vagus nerve. Both utilize the outer surface of the splenic artery to make their way to the spleen. All right, clinical correlations associated with the spleen. So spleen is the most commonly ruptured abdominal organ in the body, typically if you have a fracture in ribs 9 and 10 overall. And a rupture can be life-threatening and usually results in severe intraperitoneal hemorrhaging that can lead to shock. So here's an example of a rupture, but again, ribs 9 and 10, often when they break, you can cause a laceration and rupture of the spleen, so not good. Some diseases can result in enlargement of the spleen called splenomegaly, which you can see normal spleen here, large spleen there. Under extreme conditions, removal of spleen can be necessary, can cause abdominal pain because it's pushing on the other viscera in the abdominal cavity. Spleen can be removed without causing major problems to adult human health. And then, importantly, the splenic artery branches, which we saw here, do not anastomose with each other, and so if you have obstruction of an individual arterial branch, it results in necrosis of the splenic tissue supplied by that vessel. That's not good news. All right, can you identify the duodenum, pancreas, and spleen in this cross-section? So I think the really hard part is the duodenum, but we'll take a look. So this guy right here is spleen. This guy looks kind of like fatty tissue almost. That is pancreas. So we have tail, we have body of pancreas, we have spleen, and then this guy right here is the duodenum, and this guy right here is jejunum, and presumably this is jejunum as well. Okay, not too bad. Moving on. Can you identify spleen and pancreas? Well, here's spleen, here's pancreas, and here's the gallbladder. Okay, venous drainage of the large intestine. This should just say, tell us about the portal system. Okay, so hepatic portal vein is getting venous drainage from the splenic vein, which we know is doing pancreas and spleen. Then we have superior mesenteric vein, which is put in work for our duodenum and small intestines. And superior mesenteric vein, we know, gives off a number of different branches, right colic, ileocolic, overall for the large intestines. And then we know it's giving off branches to the ileum and jejunum. And then we have over here from the splenic vein, we have inferior mesenteric vein, and that's going to continue down. We have the left colic vein, and then we have all these sigmoid veins, and then those go down to the superior rectal veins overall. But they're going to go back to the hepatic portal vein, and the hepatic portal vein will go into the liver, which then gets to the hepatic veins, which go into the inferior vena cava, which goes back to the heart and right atrium. All right, so we kind of already talked about this. That's the hepatic portal system. In particular, if you had portal hypertension, what would you expect to see as in large vessels? And so really the places where you have portal systematic anastomoses, where the portal system is anastomosing with the rest of the venous system, so that would be at the gastroesophageal region right here. And so if you have hypertension, you can see blood in the stomach region, you can cough up blood. Umbilicus, so paraumbilical and anterior abdominal wall, and we'd see this as the caput medusa. And then down here, you can have hemorrhoids with your superior rectal anastomosing with the inferior rectal and middle rectal overall. We know that's going ultimately to the hepatic portal, so if this is super high blood pressure, then all of these veins can swell overall. All right, so that's it. Good job. We reached the end, and super long, but we did it. All right, good job, guys. Adios.